Welcome to another NIRx webinar. This one is on NIRS Studies on infants and children. My name is Thomas Johansson. I work out of the Minneapolis office. We've got team members here from our DC office, as well as Berlin office as well, that will actively be participating. Before we get into the webinar itself, just to go through a few things here. Let's try to click through. The webinar will last for about 60 to 75 minutes. And please do feel free to type any questions you have. We will make sure we try to get to all of those, but certainly we'll make note of them. We can see your questions and we can answer those offline as well, of course. The video will be recorded and uploaded to the support website within approximately a week. And with that, I'd like to introduce our speakers. So we've got Dr. Jessica Gemignani. She's an associate research scientist that works out of actually now the Berlin office for a while, but also in Italy as well as France, and she'll be able to talk about her experience there. And in particular, in her work in France, she's a postdoctoral researcher in the Gemignani lab at Université de Paris Descartes. Dr. Afrouz Anderson is also an associate research scientist working out of our DC office, as well as in working with the Focus Foundation as a research scientist. So with that, I would like to make Jessica our presenter and get things going.
Yes. Okay. Yes. Okay. Thank you, Thomas, for the nice introduction. Yes, I am a postdoctoral researcher in Paris, but I worked for NIRx for the past 4 years as a Marie Curie early stage researcher. So I'm very glad to be here today. And hello, everyone. So yes, today we will be splitting our talk in 2 parts. I will be discussing some aspects related to the preparation of the montage because it is the case that during development, during brain development, the distance between the brain and the scalp changes, and so the distance between sources and detectors should be chosen accordingly. Also, when talking about how to prepare the montage, we will be covering also how to the correspondence between the 10-20 positions and the underlying cerebral structures changes over the course of brain development, and how we can take these changes into account when planning the experiment. And finally, the last point I will be talking about is how to use an age-appropriate atlas to select the target regions of interest and how to plan the montage based on this information. So let's go. As we all know, the sensitivity of a NIRS channel, which is a source detector pair, depends in practice on 2 components. The distance between the source and the detector and their position on the scalp. The source detector distance is approximately 2 times the depth reached by the light photons. So when we choose a source detector distance, we really need to think carefully about the distance between the scalp and the cortex. We really need to know what is the depth that we need to reach because it changes a lot during brain development. So it is indeed the case that the very first few months of life are a very dynamic phase regarding brain development. Just to give you a figure, we know that at birth the total brain size is approximately 35% of the adult size, but it doubles up to around 70% only over the first year of life. So there is a robust growth in brain size, but this growth is really inhomogeneous. Some published works highlighted that some regions grow faster than others. In particular, to prepare this webinar, we focused on the study published by Gilmore and colleagues in 2007. in which they analyzed the MRI scans of around 70 newborns, and they found that the posterior regions grow much faster than the anterior ones. They suggest that this difference may explain why the maturation of visual and motor functions occur earlier than the functions associated to the prefrontal cortex. Of course, changes in the brain size imply changes of the distance between the brain and the scalp, which is also inhomogeneous. And probably this is the aspect that we care more about for our own purposes, for the purposes of selecting a good source detector distance. To the end of calculating indeed the brain scalp distance at various time points after birth for providing recommendation for NIRS research, Beauchamp and his colleagues published a study in 2011 in which they analyzed a large dataset of MRI scans acquired on children aged between birth and 7 years old, and they selected a few significant landmarks on the scalp. And for each of them, they computed the brain scalp distance across all subjects, as you can see in this figure here. So the first row represents the MRI scan of a newborn. It was 2 days old, while the second row represents the MRI scan of a child aged 7 years old. So they selected 9 landmarks in particular, and across all subjects they computed the 3D brain scalp distance, and they tabulated it, and they investigated the effect of age, of hemisphere, and of landmark, of course. And what they found, so they reported many interesting findings. So we selected a few. In particular, they found that the brain scalp distance increases with age across almost all landmarks, except for the frontal pole. As you can see from this table here, the brain scalp distance in the frontal pole remains relatively constant throughout all the brain development. So in infants, you can see that it was measured to be on average around 10.5 millimeters, and it only reaches 11.2 millimeters at 12 years of age. So the frontal pole brain scalp distance remains approximately constant. But another interesting finding was that, as highlighted here in these orange squares, at birth, the brain scalp distance is smallest in the occipital and temporal regions than in others. So for example, you can see that in the occipital landmark, the distance was measured to be only around 5 millimeters at birth, and 5.6 until 5 years old. So really a minimal increase. And in the temporal landmarks as well, the distance was around 6.7 and 8 more or less millimeters respectively at birth. So this is another finding that one should keep in mind, as we will see in a moment. And lastly, in this work, they also found that at birth, the brain scalp distances in the left hemisphere are a bit smaller than those in the corresponding landmarks of the right hemisphere. As for this finding, the author suggested that this may be due to an asymmetry in brain size between the left and the right hemisphere at birth. So the left hemisphere is bigger than the right hemisphere at birth, while this asymmetry seems to be the opposite in adults, and it also seems to be more moderate than it is at birth. So in order to provide you with recommendations, because that's what we would like to do today, is to provide practical recommendations for the preparation of the montage, we reviewed many papers published between 2000 and 2019. Now, you cannot see very much this list, I believe, but we will make available this list soon as a technical note on the NIRx Help Center shortly after this webinar. So we reviewed, as I said, many papers published on infants and children studies published in the last 19 years. We grouped them according to the age of the participants, the type of simulation, the regions, the covered regions. And what we found is that As for many other aspects of NIRS practice, there is no real standard, but that most commonly the employed source detector distances range between 2 and 3 centimeters. So what is how, based on these findings, what is our recommendation in practice? We believe it is about finding the perfect trade-off. Of course, the same age groups are sometimes investigated with shorter source detector distances, and in other studies with longer source detector distances. So with shorter source detector distances, there is a on one end, so the shorter source detector distances, on one hand, definitely yield better signal amplitude, okay, and so therefore a better signal to noise ratio. On the other hand, there is a huge risk of sampling the superficial layers instead of the cortex. On the other hand, a longer source detector distance may yield a lower signal amplitude, and this may be problematic, especially when testing infants, because we know that already that testing infants is already challenging. I mean, getting a good signal quality is challenging when testing infants. But on the other hand, it is a safer choice using longer distances in order to be sure to be reaching the cortex. So our recommendation is, as for the source detector distances, is to carefully check the literature relevant to the age of your participants, and check the literature, keeping in mind that different regions at the age that you are investigating may display different brain to scalp distances. This is really crucial because, as the work that I mentioned, the work from Beauchamp and colleagues in 2011, they highlighted that it's really important to do this work because you really want the difference between the measured hemodynamic responses at different sites to arise only from a different functional effect of the task and not to be due to the different brain scalp distances. So you need to make sure that these differences are not a confounding factor in the statistical analysis of your of the obtained hemodynamic responses. So once you fix the source detector distance, as we said at the beginning, the next thing we need to think carefully about is how to position the optodes. So we know that when working with adults, if we position the cap properly and we use the right cap size and we place the optodes according to the 1020 system, then we can refer to a probabilistic correspondence between these positions and the underlying regions of the cortex. This correspondence was published already quite some time ago, and it's been used ever since in many studies. Now, unfortunately, there is not much literature on the subject of how this correspondence change for younger subjects, okay? But we selected this work that was recently published by Claire Capdebon and her colleagues, where they acquired MRI scans from infants, and they registered the scans to an atlas that they developed from one of the subjects. So all these subjects are all newborns, so up to 2 months of age. So their goal was indeed to investigate whether the correspondence between the 1020 system and the anatomical regions as established for adults hold valid also for newborns. Okay, and they found that it mostly does. So in most cases, the regions on which the 1020 positions project are broadly the same in newborns as they are in adults, except for the occipital locations. Only the occipital locations exhibit exhibit a significant difference in that the pairs of electrodes, especially T5, T6 and O1, O2, were found at birth to be lying just above the inferior limit of the brain rather than a bit higher as they do in adults. So while in the adult population they correspond to the middle occipital and middle temporal gyri, in infants they project on in more inferior regions. That is what was found on infants. Other than that, the 10-20 positions broadly in children broadly match the positions in adults. So how can we proceed from here? What are the practical implications of all this when it comes to designing the montage? So when we work with adults, we are facilitated, okay? In that there are already some software tools like Fold that allow to design the montage based on selected cortical regions that we want to target. So Fold basically outputs, so based on the cortical regions that you want to target, it outputs the positions, the 10-20 positions that are most likely to project on those regions. Unfortunately, Fold, I mean, not unfortunately, but Fold was developed on with adult head atlases, and at the moment, unfortunately, there is no similar tool working with developmental atlases. So there is no automatic way of doing exactly the same when we work with children. So what can we do? Again, in the same document that will be released on the Health Center, we put together an extensive list of atlases that are grouped by age, and they span from fetal atlases built on prenatal MRI scans to adolescent atlases. So what we recommend is that you choose from this list the atlas that more closely matches the age of your participant, and some of these atlases already provide the corresponding 10-20 landmarks. This is, for example, the case of the head model introduced by Sabrina Brigadoy and their colleagues in 2014. In that case, they provided 10-5 positions for every head model between 29 and 44 weeks of age. So it's really only for infants, it's not for children. Anyway, there are more atlases in that list. And you can look them up based on the age that you need to cover. After that, you can, once you know the 10-20 positions, you can really design the montage to be employed with the NIRx systems with NIRS site. So the current version of NIRS site at this moment works with an adult atlas, the ICBM 152, but a version that integrates pediatric atlases is being actively developed right now, and it will be soon available during this year. So once you have a montage ready to use, once you have the 10-20 positions that you want to employ, you can design the montage with NIRS site, and once you have the montage with NIRS site, you can start data acquisition, and then you may, if you need to, after data acquisition, you should register the age matched atlas that you used and the individual head size and shape, just like you would do when working with adults. You would register the individual measurements to an atlas, to a standard atlas. So this was it for the aspects related to the arrangement of the optodes. Now I leave the floor to my colleague, Dr. Anderson, and at the end we'll be discussing your questions also about this part.
Thank you so much. Just give me a second so I can.
Yeah.
Okay, can you see my presentation?
In the notes.
Okay, sorry about that. Okay, how about now?
Yes. Good.
Okay, great. Okay, so, all right. So today I'm going to cover the experimental design and setup. My colleague Jessica already covered all the important aspects using the channel registration and how we can proceed from there. And I'm going to cover the experimental design and setup in children and infants. So just before I start, we have covered previously some of the aspects of the study types, and these are the study types that can be used both in children and adults. But to just a little bit brush up on these topics, one of them is the hypothesis-driven, when you have some sort of prediction based on the previous data. This previous data could be based on the fMRI, it could be based on the NIRS assumptions that you previously have, or certain cognitive functions, certain region. But what happens in infant and child study most of the time, let me get my highlighter going here, is that you have more of the exploratory base. And why is that? Is because there's a lot of unknowns in the brain function, developing brain from infancy to childhood. So that becomes harder to have a lot of hypothesis driven. That's where we start looking at the exploratory base. We look at the different function, we look at a different region. We try to understand from the data that we produce what are the outcome and how these, for example, cognitive function can change with the development. The other way that you can look at your data in general is the data-driven, which was the prediction based on a large amount of data. Suppose that you have a lot of pattern that you can derive from your hemodynamic response changes. And based on this pattern, you can use some sort of classification method to look at, for example, if different brain regions are showing the different patterns. And there's no assumption, prior assumption in the data-driven approach. You need a lot more data, but sometimes it's very useful in infant and children studies. All right, so how can we make our exploratory analysis stronger because it's exploratory? So one way to do that is to gather data across several cortical regions and channels to be able to, for example, look in the development, especially in children. We know that different cortical region can have a different development or hemodynamic response. So it's a good idea to be able to look at the broader region and underlying neurocognitive function, and also combine with the conditional task. This, again, makes your analysis stronger, not just use one type of task, but, for example, use different types of stimuli for the same task. Let's say you have a joint attention, you can use a different type of video stimuli, or you can use a different type of emotions or social interaction to look at the tasks that you're having, and also combine with other available data. And I really think this is one part that can make it stronger, especially in infant and child study, because we are trying to understand the brain development, and it's just not, so it's better to have some good correlate to make your analysis stronger. So one way to do that is to include some of the behavioral data in your analysis. This behavioral data can be attention span, it could be IQ, but it also could be physiological based data. And what I mean by that is sometimes you can, for example, look into the activity in the kids and try to correlate the brain function, for example, with the amount of activity that kids have had. And I have some example study that I'm going to show at the end. And again, combining with NIRS data, the other way that you can do that, combine NIRS data with your behavioral data, is to, for example, look at the changes in the hemodynamic response with the length of eye gaze, for example. It becomes very important sometimes in the infant study because most of tasks are passive, is for kids, for you to have some sort of measurement of like attention, either through like a video decoding or however you want to do that. But one ways to do that. In child studies, you can looking at the correlation between changes in the brain function and the correct response. Obviously, this is harder in infants, but in children that could be done. And infants, you can, for example, find a correlation between the social behaviors and changes in hemodynamic response. This social behavior could be based on familiar faces, unfamiliar faces, and parental stress, and so on and so forth. The other way that you can really increase the a strength of your study is to look at the longitudinal study. And I think one of the particular area that FNIRS is very strong is it allows you to do easily like a longitudinal study. And why is it important? Because it gives you the early prediction to understand the later life outcomes. So for example, you can look at a kid doing some sort of attention or inhibition or familiar, unfamiliar faces. You start from the very young age, and you can do this longitudinal study to look at and see how the brain development is changing, how the cognitive function, how the neurocognitive function is changing with respect to the age, for example, because we know that a lot of this function can change with the brain development, so it's a great way to look into it. All right, so there are several task design strategies that you can use, and again, similar thing can be applied in adults. One is the simple block design. Again, you can use auditory stimuli here. I'm giving the example of like a very simple go, no go task. The problem, for example, in this case, we have series of the spaceship. We ask them to click whenever they don't see the red spaceship. If you design it as a simple block, what happens is that you have all your green data here, green spaceship here, and all your red spaceship here. So it's increases the fact that it's going to be data are going to be predictable, and the predictability in the infant and child studies are pretty big issue. So you have to be careful about that. So it can reduce the psychological effect that you actually want to look at. The other way is doing the event-related design, and that's sometimes is more preferable in infants because given the attention span, given that having the familiar or unfamiliar stimuli can affect the hemodynamic response and attention span in infants and children, this event-related design might be better. For example, you will just show one surprise stimuli at a different time. So that way, you can sort of characterize the shape of your hemodynamic response. Here is more like about the amplitude of it, versus in the event related is about more shape of it. But you need more trials, so you have to be aware of that because you want to increase your signal to noise ratio. The other way to do this task design is a mixed block design, where, for example, in this case, again, I'm giving the example of the go, no go task, but you can use auditory, you can use different emotional balance videos that you can use in this case, or the stimuli that you can use, like images. But what you would do in one block, you will use the just the go stimuli, which is green, and for the other block, you will use the different stimuli, both go and no go. So that way, you sort of mix the event-related and simple block design in a way, if you want to think about it in this case. And a lot of the studies use that because it's very efficient in detecting a hemodynamic response given your task design. The different type of tasks that you can use, obviously one of them is active task, where there's, what I mean by that is that the task that requires a response from the participant. Obviously this is going to be harder. It's okay with the children, let's say age 4, sometimes you can do that, age 3 you can do that, but it's much harder in toddler and obviously infants, that you cannot really ask them to respond in the particular stimuli that you want. So therefore the passive tasks become much more feasible. There's no response required. You still show them or present them with a certain stimuli, but you just ask them, and you look at the brain function as they're, like, for example, seeing this certain stimuli. You can use the eye tracking or video decoding software, or you can do it in MATLAB to, for example, look at the attention span, how much they're paying attention. It's another example, it could be a social interaction between the mother and child, familiar and unfamiliar faces. So these are all the examples of the passive tasks where you show the stimuli, but you don't require the response. It could be also based on, like I will show you in a study of like using odors in infants, for example, to look at the brain function. And the resting state. The other way that you can look at the data is using a resting state. Again, very feasible with infants and children, depending on what kind of setup that you have. You basically, the infant is asleep, you put it on. In toddler, some people and some researcher, what do we do is like we use videos to increase the compliance during the resting state. But you have to be very careful in this case because the emotional balance of the video can affect the cognitive function. So maybe, although we call the resting state, but you can look at the very calm videos to just basically have increase the compliance, so there's less motion artifact or movement in children and infants. You can also modify tasks. Again, it depends on your age range. Here on this particular slide is for children of like 3 and above. But for example, let's say you have an M-back task, but you can change the type of the stimuli. It can still be an M-back, but for example, you can use the shapes in this case instead of using a letter. That makes it easier because they're sort of familiar with these stimuli. Let's say you have a Stroop task in adults versus children. In adults, for example, you have 2 different stimuli. Condition A would be you show the stimuli with the same color, so it would be the font would be color green, and the writing is also green, and you have asked for a response for the participant to say green or click on the green button. Versus in the condition B, where you start to have a Stroop interference, you write the letter green, but you put the color red, and you ask them to read the word green, but responds with the color, which has, for example, has a slower response. The same thing can be done in a children's Stroop. It's called a day and night, for example. It's shown to have a similar effect, where you would show, for example, the picture of the day, and they have to respond the night, and vice versa. Be very mindful of the task complexity. Task complexity can have a huge effect in the neurocognitive function in infant and children. If your task is too simple or too complex, it has been shown that the toddlers start just drifting around and just not paying attention. You be careful of effect of habituation. If you're showing the similar stimuli for too long, it's just, you know, they're not going to start paying attention, and that's where you have to start worrying about. But again, novel stimuli can increase the interest of the infants, especially, or toddlers. So mixed block design or even related can work better. And why you have to be very careful about this task complexity is because at the end of the day, we're looking at the changes in the hemodynamic response that can, because it's based on the neural activity, and it depends on the processing and cognitive effort. So if you have a task which are too simple or too complex, you're obviously going to affect the processing effect, which will in turn will have effect on your hemodynamic response. Some of the analytical consideration, a lot of it was covered by my colleague, but infant and toddlers, you have less problem compared to adults with the scattering due to the skull, for example. You can use a high density caps or just a topography caps to basically probe a different depth. For example, you can look in the shallower region and a deeper region, but again, using the high density caps in infants are harder. So you have to be always aware of these considerations when you're doing these studies, because if, for example, if you're using the fiber base, then it's going to make the head heavier and it's going to be harder. And then be very careful about what assumptions you're making about a hemodynamic response pattern. Changes in the hemodynamic response, it has shown that, for example, the hemodynamic response can be very different in adults versus children and toddlers. There are some weird pattern has been seen previously. For example, the fact that hemodynamic response, we always prefer to see the canonical function, you know, increase in the HBO, but sometimes we see completely different way. Sometimes we actually see the unidirectional changes in the hemodynamic response. And a lot of this can be due to the fact that a lot of, because hemodynamic response is a very complex function. It depends on the neural function, it depends on a lot of cellular mechanism that in infants, for example, is not matured yet. So it's very important to have take a look at your data beforehand and just make sure you look in a different area, because sometimes the other thing is that different brain regions are developing at a different speed during this time. So that's why you want to look at a different brain region, just because to be able to correctly look at the hemodynamic response. And again, if you do longitudinal study, that's going to help you a lot to be able to see if different brain region are having the different development of like a underlying developmental neurocognitive function. Also, the timing of hemodynamic response has been shown to be different compared to the adults versus children. Sometimes it has been shown to have some sort of a delay, the timing, the peak of the hemodynamic response has some sort of delay. So you want to pay attention on those and do your background research beforehand. You can, in your analysis, for example, if you're doing resting state or a long period of the stimuli, you can use a functional connectivity analysis, basically looking the correlation of the time series between the channels. This is one of the examples. For example, you have channels on each side, and you can look at the the correlation of the time series between the channel. You can also do the hyperscanning studies, which are very interesting, and they're increasing in the number of the studies because basically you look at the synchronization of the hemodynamic response between two or more subjects. Here is an example of, for example, in case of reading with a child, you can use a correlation analysis, or you can use a dynamic time warping, depending on your choice of how you want to look at the hyperscanning studies. For the hyperscanning studies, there are some consideration you have to have. Think about the position of the source and the detectors, because you're looking at the adult subject and you're looking at the child subject. So just make sure that the regions that where you're putting your probes are matching in both. If, for example, if you're using a NIRS cap, here we have already the 1020 system positions that are showing on the cap, so that sort of makes it a little bit easier to make sure that you have a correct positioning for the channel, but just pay attention to the correct placement, basically. And in the opto distances, obviously, is going to be different, right? Because usually for children and infants, we use between 1.5 to 3. For adults, it's 3 and above. And it's okay, you can do that as long as your regions are sort of matching. You can include the distances, the distance differences in your Beer-Lambert law to account for that. And also consider to change the differential path length factor in the analysis that Dr. Gemignani has already covered in the analysis. And I just want to briefly touch up on that. For example, changing the skull thickness can change with the gender and age. So if this is your hemodynamic, the Beer-Lambert law, which you're looking at changes in the optical density, you have the changes in the differential path length factor that can change with the age. So you can, for example, look at this paper by Skolkman when they looked at the equation of the differential path length factor with age. And also some of the new study that came out by Dr. Hubbard group, for example, showing the differences in the male and female in children, especially in the temporal area and the frontal region. So, and this paper also provides the differential path length equation that, for example, you can use and consider in your analysis. Some of the hardware consideration, you can use both the head cap or the specialized headband that we provide. Cable management becomes very important. In my studies, most of the time, something that I call like a freestyle. What I do, I hang all the probes from the top, so there is no pushing or pulling of the probe, although this is a NIRS Sport 2 system, very lightweight system, so it's not as much of the problem. But let's say, make sure that everything is secured. In this case, for example, this is showing the tree, that all the optics and fiber optics are secured by the tree on the headband. Again, depends on your choice preference. Always use an arm, or for example, I use sometimes the IV pole. The arm is great because it gives you a lot of flexibility to move your fibers around. Always make sure it is higher. We provide this, for example, with our system. Make sure it is higher than the subject head so it doesn't create a pulling effect. This is the way sometimes I do it in a hospital setting where I have, for example, my NIRS Sport 2 system in the bag. Again, you don't have to do this setup, but you can just put it on the IV system and move it around, and then it will hang from the top, which can make it easier in case of infants and children. You want to also think about the probes that you're using. We have a blunt tip probe that is ideal for neonatal and infant. We also offer the dual tip optodes that is ideal for the subject ages 1 and above, but you can, I have had a very good luck using them in infants as well. And then you can also, we have the probe, a specific probe for combining the NIRS and EEG, for example, for infant monitoring in this case. NIRS 2 is, in my opinion at least, it's much easier for movement studies or infant studies because of the very light probes that can be easily placed on the subject, and it's easy to go around. It's also equipped with accelerometer, which is a very good piece of information to have, especially if you're looking at the children and toddler. So you can look at, for example, amount of activity and be able to sort of correlate that with the motion artifact if necessary. And this is an example of the NIRS 2 system that we have and different tips that you can use with the system as well. You can also do the integration with other modalities such as EEG, fMRI, and eye tracking. Eye tracking specifically becomes, in my opinion, important if you're doing the infant or child study or toddler studies, because one of the best way that you can sort of quantify the attention to the stimuli. Let's say you're having the stimuli that is moving across the screen. Using the eye tracking system, you can basically, for example, have some sort of index for how much of attention the subject is paying attention. And we also offer the integration with the EEG system. If you're interested in the fMRI, we also have a compatible fMRI compatible probe that can be used for both infants and adults. Our system also covers the hyperscanning capabilities. And this becomes very important, especially in infant and child studies, looking at the sort of social aspects with parents or with familiar faces, unfamiliar faces, and joint attention. The hyperscanning capabilities becomes important. And I just wanted to mention, for example, the NIRS Scout system and the NIRS Sport system both can be connected to create a to connect the different individuals, for example, to record the brain function from the several individuals at the same time. This was just an example of the Aurora software that can automatically do that. So you can add as many as device that you need. Some of these studies I want to cover here that, for example, these studies in particular have used the different NIRx system. One of them is understanding the interaction between the mother and child behavior. In this study by Ajari et al., what they showed a different video clip. Again, you can see the stimuli is passive. You're looking at the Peppa Pig, Brave video, The Incredibles, and they looked at the, for example, as part of the study, I'm not going to cover the whole study, they look at the parental stress and the synchronization between the child and the mother signal. And this synchronization, I believe they did it with, for example, DGW. And the higher distances, the more distances, it means there's more desynchronization. So, for example, it showed when the parents have a stress, you have less synchronization between the mother and child. And you can see, for example, the probe placement was in both SFG, MFG, IFG, and prefrontal cortex region, both left and right. This is another example of the group attention and teacher-student interaction. For example, in this case, they look at the prefrontal cortex function, and they looked at, for example, the lecture at the different blocks, and they showed that there was a huge synchronization at the beginning of the lecture, but as the lecture prolonged, there was more of a desynchrony between the student. Here's an example of the 4 subjects that, for example, you can use. And this is about using a teacher-student interaction, for example, on the counting board game. And they were showing like a different region that is activated in the teacher versus the student. This is the area, for example, that takes care of like emotional attachment, and they were trying to understand how this correlates with teacher versus the student function. This is another example of the a study that has been done. This is not a hyperscanning study per se, but they use the NIRx system to look at the response of the newborn to the different odors in the hospitals. For example, it could be cleaning supplies, or it could be alcohol wipes, and so on and so forth. Again, they did a comprehensive study. You can see that they look at the temporal regions like this. And this is one of the examples. The analysis for this particular result has been done in a NIRS lab. And as this is the pre-stimuli, and this is during when they started smelling the odor while they're asleep. And this is, you can see both the behavioral stimuli, if you can see the facial expression of the infant, as well as the increase in hemodynamic response in the temporal region. And this is another example. This is not using the behavioral per se result, but some of the physiological aspect. So they look at the kids who had a moderate to vigorous physical activity using the accelerometer, and they look at the executive function. For example, they look at the verbal fluency task and a mental arithmetic task. And at the end, they showed that although the verbal fluency and arithmetic task can affect the frontal function, but this did not differ between the subject who did a moderate versus vigorous physical activity before doing these tasks. So these are just examples to show the different way that you can look at your data. And some of the final consideration, always practice on how to put a cap on, and make sure, try the different cap solution to see which one works better. Is it the partial better versus the whole head would work better? Sometimes if you're just looking at a very certain location, partial might work better for you. So pay attention to that. Sometimes some of the researcher, including myself, depends again on what a study design you have, but during the putting the cap, which is you can put some videos to distract them while they're looking at the screen. You can put a cap on, and ensure that their hands are off the cap. If they're sitting on a mother's lap, for example, you can always ask them to sort of like put their hands like this on top of their hand, and so that might work sometimes, so they won't yank. And one thing I always suggest is to try the cap on the participant if you have that option before the experiment. For example, if they're coming to your clinic or they're coming to the hospital setting, have someone to go and just say, hey, do you want to see this cap? Do you want to try this cap? Put it on. And that way they become familiar with the cap and what's going to happen, because they're smaller kids, it's harder to explain to them. But also parents can see what's happening and they get more used to the cap. And with that, I want to thank you for having me here. And if there's any questions, please let me know.
Okay, fantastic. Thank you so much, Dr. Anderson and Dr. Gemignani. With that, I just wanted to check with the organizers there. Hey, we've got Lamia Pashalic and Made.
I just wanted to mention something. I'm not sure, Jessica, please apologize. Excuse me if you already mentioned this. So we are working on implementing new head models specifically designed for infants to be implemented in your site. And this should be available quite soon. So, oh, okay. And we hope by the end of the year, maybe even sooner, we will be releasing them progressively as soon as we implement them. So we will start with the newborn and start expanding from there to add a few more sizes, then progressively add toddlers, and maybe later on even children. So we do have a question, would be, is the inter-subject variability of infants of similar age similar to adults in terms of location hemodynamic responses? So I will read it one more time. Is the inter-subject variability of infants of similar age similar to adults in terms of location of the hemodynamic responses?
The location of the hemodynamic responses?
Yes.
So I maybe Afrouz later knows more about this, but there is a lot of inter-subject variability in children and infants, definitely more than in adults, not the same, more than in adults, and is currently actually an open question. I believe there is a paper that was super recently published by the group, by Scholkman's group, where they highlighted that there are potentially subgroups as for the shape of the hemodynamic response. So I think they reported that the hemodynamic response shape can be grouped in 3 different patterns in infants and children of the same age. So I'm not sure this, at least, yeah, I'm not sure about the location, but definitely the shape differs a lot from one subject to the other, and it's an open question, really. So.
Yeah, thank you very much. And maybe Afrouz, I just wanted to say that that's exactly what I wanted to say. I did not there. I think there is much more variability in children or infants, even if they are approximately the same age. And I know some researchers who don't even want to use the standard canonical hemodynamic response function because this has been studied and designed for adults. And when they do analysis, they rather do data-driven rather than model-driven approach. Sorry, Afrouz, please go ahead.
No, I was completely agreeing with that. And that's what I mentioned. One of the biggest things is like when it comes to analysis, I think the problem is less of the variability in terms of the location, if that's what they ask, because most of the brain location, they don't change drastically. You know, you have some sort of like, you know, your brain starts like growing, right? But the biggest thing that, again, as you mentioned, and Jessica also mentioned, is that the shape of the hemodynamic response. You cannot, a lot of times when you're modeling that, if you're, let's say, if you're doing the GLM analysis, I wouldn't do that. I would start with something of looking at like a time course of hemodynamic response. And also, I would worry about in infants. I've seen the differences in the preterm versus those infants that were born preterm. Let's say you're looking at the 10 weeks, but those who have preterm versus those are not, you want to pay attention to that, because sometimes some of the vasculature, and if there's any effect on that, that then in turn can affect your hemodynamic response, like some of the physiological underlying physiological issues that can affect the hemodynamic response function as you would predict. So that's what I would be more concerned about than just the location.
Okay, and the third question, Afrouz, is specifically for you. But what kind of accelerometer do you use within NIRS Port 2? Does it add a lot of weight to the cap?
So the accelerometer that I use, it already comes with a system. It's very small, so it's just the size of the probe. They have it here, but it's similar to the probe. It's very lightweight, and we just basically put it in one of these locations. Let's say you have a several location, and you can decide, like, for example, you can just put it in the back using a standard grommet that we provide. So it is not heavy at all. It's just part of the system. I don't think it makes any difference in terms of weight limit on anything. So that's what I use. Yeah.
Okay. And let me just give more detail, because I know Anne. Hi, Anne. Thanks for joining us. So I know you do have a NIRS Port 2, and probably you don't have an accelerometer, but that's something that you can always add. So the way it works is basically you add it as a 9th detector. It looks exactly, as Afrouz said, like an output, like a detector, and you open the breakout box of the detector and add the accelerometer, and it will be supported in the software. So for the moment, within in the Aurora side, we only have a display of the movement based on the data that comes from the accelerometer. We do not have any algorithms for analysis for regression of motion in NIRS lab, but the data is anyway saved, and if you have your analysis pipeline and your algorithms, you can definitely use it to do some regression. Okay, I think that was the last question for the moment. Okay.
I have a question.
Yeah, go ahead, Thomas. You can make a question to him.
So this is for everyone, for both panelists. What is it that excites you most in what you've seen, in general from the field and from technology advancements about how a thing related to how infant and child FNIRS is changing? So Afrouz, why don't you go first?
Sure. I think
one thing. You don't have to say everything.
No, but one of the things that definitely excited me the most, has always excited me, is like having some sort of non-invasive way to be able to look at the cognitive function, right? because at the end of the day, we are trying to understand both behavioral changes and the brain development. So I think that's very exciting if we can finally have some sort of clear picture, and that's where I'm very excited about doing my studies as well. We now have the devices that are so lightweight. It's so easy to, for example, I personally use a NIRS 2 system. I can easily take it to different clinics. I'm not bounded to just having 10 subjects a year now. I can have 30 subjects if necessary, because I can go to the subject. And to me, the excitement comes, again, we talk about the shape of hemodynamic response, and I think those matters a lot. That actually excites me a lot. The timing delay of the hemodynamic response excites me a lot, because what if the differences that we see in the maturation, it's completely depends on a physiological aspect of the infant itself, and not just behavioral. So because these are all interacted, right? They all interact with each other, all affecting each other. So I think it's a very nice era. I think there's an increase in the rise of the NIRS studies in infant, and I really hope that within 5 to 10 years, we will have much clearer image of what's happening in the brain development.
Great, thank you. And
Jessica?
Yeah, sorry, I was waiting if, yeah, for me it's maybe it's because I'm mostly concerned with data analysis, at least for now. So for me, the most exciting, so compared to articles written in the past, right, where we had only couple channels, 3, 4, 5 channels. Now we have fuller and fuller coverages of the head, and people are starting using more and more data-driven methods rather than the usual methods derived at the end from fMRI, right? And I think, I read a lot of papers mainly for writing my thesis recently, so that's why I'm very well informed. And I think we are getting more information now out of these signals. I think we're getting more, at the end it's more knowledge, right? We can really for example, decode even mental states. It's not anymore about measuring the effect of a task with respect to another. It's really about decoding even what someone is even thinking. And I think what excites me the most is really to be able to exploit more of the same signal. And this is thanks to, I believe, is thanks to the fact that we have fuller coverages now than we had years ago.
Great question, great answers. Thank you. In the meanwhile, we have another one. Which depth of cortex can be reached in infants?
In terms of
I guess the photon banana and yes. How does the same?
Yeah. So it depends on the source detector distance. So if the source detector distance is, let's say, 2 centimeters, then you are going to reach 1 centimeter of depth. Now, then the question is to understand if this is enough or this is too much, and that's what we tried to cover today in the webinar. And we see that sometimes in infants, 1 centimeter of depth is well enough to reach the cortex, and the risk of doing even a larger source detector distance is to go even beyond the gray matter at the end, right? You risk going too far from. So that's why I wanted to stress the point that one really needs to check the literature relevant to the age of choice. You don't want to go too far, because otherwise you're not sampling the cortex anymore. You're going too far, you see?
Yeah, exactly.
I think the depth, let's say that the brain to scalp distance is 10 millimeters in some areas. In some areas is even less. The cortex is only a couple millimeters, I think, right, Afrouz? I think it's around 4 millimeters in adults, and in infants, so it's even less. So you need only to add a couple millimeters to the brain scalp distance that you want to cover. Is that right? Can you confirm, Afrouz?
Yeah, that's all correct. I completely agree. It depends on the source detector distance that you want to put, but also some people actually use the different distances in infants just because you have such a less noise that is coming from your skull, such less scattering due to the skull. So if you're not just interested in the cortical region, in infant you actually can go subcortical in your studies if you're interested in that. But then you have to have a lot of consideration and, you know, doing the several channel distances as Dr. Gemignani mentioned.
But that's exactly the danger. I just wanted to point it out because unlike for adults, it is technically possible to increase the distance very much. So even if you put a source on one hemisphere and a detector on the other hemisphere, you may even want to have you may even be able to reach good signal. And that's why we should be a little bit more careful. So if you really want to do it, because most probably you do not want to do it. So unlike for adults, it's very easy because anyway, you're limited technically by the penetration depth. For babies, you are actually not, but you, as both Jessica and Afrouz explained, you should be very careful if you really want to increase the SD distance. Okay, so we have a few more questions, or actually it's only one. Using smaller distance between sources and detectors could increase saturation problems when working with infants. What are the recommended hardware characteristics, types of source and detectors when working with infants? So I see everyone wants to answer this one.
I believe she has some experience on that.
Go ahead.
No, I just wanted to say one thing. That's a great question. So if you're using the system that you want to change a source detector system to reduce the saturation, you have to play with two options. One is your detector gain. The other one is your source intensity. These are the two things that you can play around to, you know, get rid of the saturation problem. Now, one of the great things that I've seen, for example, in the, let's say that's the option for the NIRS 4.2 system, is that the detector has a certain gain, okay, but then automatically what system does, it changes the intensity of the signal, intensity of the source. So it will accommodate for the fact that it will reduces the source intensity in order to reduce the saturation issue. Or if you don't have a saturation and you need more signal, it will increase that. So in order to compensate for the fact that you have several distances. So this in all our system, we incorporate that into the calibration mode. Like, so most of the system that you should be considering is a good calibrated system that calibrates for each individual. Because again, the hair color can matter, will matter, the skin color will matter. So you want a system that can calibrate for you automatically. And if you don't, then you definitely have to play with the gain of your detector or the intensity of your sources manually, which can be time consuming in my opinion.
Exactly, and if you really ask about particular hardware characteristics, sorry, I would always go for single tip sources or detectors. I don't know if you have the possibility to choose. Of course, you know, you have to run the whole study with the same hardware. And some babies may have darker hair and some may not even have any hair at all. So you would have to, you know, optimize the best type of sources for the entire population. But generally, if you know that you're going to do studies only in babies and maybe only in the prefrontal cortex, definitely I would use always silicon photodetectors instead of APDs and single tip detectors instead of dual tipped, because they are actually meant for difficult subjects. So. Okay, I think that was the last question so far. So it's also about time. The time we had planned for the webinar is slowly expiring. So whatever, as Thomas mentioned at the beginning, we will be uploading the video in a few days by the end of the week. And feel free to contact us if you have any additional question on the topic. Okay, thank you all for participating.
Thank you.
Thank you.
Thank you.
Thank you so much. Bye-bye.
Bye. Bye-bye.